My name is Mac McCullough. I'm the Deputy Director for the National Safety Net Advancement Center, or SNAC. We're delighted that you're able to join us today for the webinar that we're hosting in close partnership with the National Association of Community Health Centers, NAC. We have a really excellent lineup for you today of speakers who are really at the front and center of the initiative to modernize our healthcare payment system. The title of today's webinar is Payment Reform for Federally Qualified Health Centers. I think you'll see we end up taking a broad look at a lot of things. Just a couple of quick notes before we get started. First, we are running all the audio through the phone line today. Hopefully that will simplify things for everyone. If you could please mute your phone audio and then mute your webinar speaker as well. That will ensure that we don't get feedback or trouble hearing speakers when we're together today on the webinar. So the instructions to mute your webinar speakers are shown here. There's you may see a green microphone button up at the top of your screen right next to the meeting layouts, pods, and audio tabs. If you could just make sure that that is muted, that should be a white button. That would be wonderful. And then you may have questions or comments as we go along today. Please enter those into the chat box that's shown here to the right part of your screen. We'll go ahead and record the questions and make sure that we can answer all of the questions and respond to the comments and feedback that we get towards the end of the session. So just a quick overview about the Safety Net Advancement Center. The purpose of SNAC and our goal is to transform the ability of safety net organizations to respond to payment and care delivery reform initiatives. We're working with more than 50 organizations across 30 states. Collectively, these 50 organizations serve somewhere in the neighborhood of 1.5 to 2.5 million. I know that seems like a big range, but it's I'm sure you're well aware. It depends on how you count these things. So SNAC is grateful for the support of the Robert Wood Johnson Foundation. You can learn more about SNAC at our website, safetynet.asu.edu. So today, we start off with the understanding and the sort of the perspective that payment reform is hard. It's hard for everyone. But we think that there are going to be some unique challenges for organizations such as community health centers and FQHCs, organizations that are focused on serving the underserved. So we are hoping to explore today, and we will explore through these presentations, so in what capacity are community health centers and FQHCs participating in payment reforms? What reform challenges are facing these organizations, and how are these leading organizations making it work? And then just sort of looking forward, what important next steps loom on the horizon for us? With that, I'd like to pass it to Dawn McKinney. Dawn is at the National Association of Community Health Centers, NAC. She's the Director of State Affairs there. Dawn, please take it away.
Thank you, Mac. Good afternoon, everyone. The first slide that we have here for you is a map of Medicaid ACO activity. This is actually a much smaller look at what's actually really happening out in the field. This only captures state Medicaid ACO development. We all know, and we're going to hear from a couple of the states actually, neither of the health centers that are on our call today to talk about their Medicaid ACO experience actually show up on this map. So we know for sure that there's a lot more happening out there than what's on this map. But this is just to give you a taste of some of the things, statewide projects that are currently underway or under development. And obviously Medicaid ACOs are just one part of payment reform. And so I think you'll hear also from some of our speakers about broader issues around payment reform as well. I wanted to, obviously, it's important to know what's happening at the state and local level. It's important to know that your vision, your organization's goals are, how any sort of effort that you engage in might get you towards the triple aim. And also, it's really important to understand your capacity and current operations, and then working collaboratively with others, health centers, and much broader. So with that said, I would love to point you towards a resource that if you haven't already taken advantage of, I would encourage you to do so. We have a readiness assessment tool for payment reform on our website. It is very robust and covers different core competency areas for health centers to assess their level of readiness and also identify gaps that they can address on their own or with the support of their primary care associations, who are so key to moving these efforts forward at a state level. So definitely would encourage you to check that tool out, and then all the other resources that we have on payment reform on the website as well. And with that, I'm going to turn it over to Dan from Esperanza to present their experience with their ACO.
Great, thank you very much. It's a pleasure to be here this morning. My name is Dan Fulweller. I'm the CEO of Esperanza Health Centers. We are a federally qualified health center located in Chicago, Illinois. And this first slide here is really to just remind us sort of why we're all doing this work. Esperanza's values are hope, health, and family, and I think that those are probably pretty congruent with a lot of other health centers in the country. And I think that they're also really congruent with what we're looking for in payment reform. Payment reform goes way beyond just looking at the medical patient in front of us at the time that we're meeting with them or that our physicians are meeting with them, but goes much more into the community and the social determinants of health and looking at how we can keep patients healthy and keep them out of the healthcare system. So I did want to put some of these pictures up here just to show you what Esperanza is doing and that I know that many of your health centers are doing as well. So a brief overview. Esperanza was founded in 2005 as an FQHC lookalike. In 2012, we achieved our 330 funding, which was a big moment for us. We have 3 sites in Chicago, Illinois. And for a Chicago health center, we're pretty small, but I think we're sort of average across the country, about 18,000 patients and 75,000 visits every year. We had $13 million in revenue in 2016, and the vast majority of our patients are Latino, and most of them prefer to speak Spanish with their provider. So we are serving a very special population base. So you can see we've grown pretty rapidly over the short time of our existence, and especially since we received our FQHC funding in fiscal year 2012. So what's the background in the state of Illinois? As you might have heard from the national news, we have some pretty significant budget problems in Illinois, and those go back quite a while. Starting in about 2011, the state had a $2.7 billion budget, and of course, like many states, Medicaid is one of the biggest parts of that budget. And so state lawmakers really made an effort to try and address some of those issues. They passed a law at the time that required 50% of Medicaid recipients to be in what they called care coordination programs by 2015. And I think you probably all know that ACOs have been a very rapidly evolving type of organization in the United States, and this was really at the time or before they even really existed in large part. So the state of Illinois was really looking at a sort of ill-defined program called care coordination to aim to work towards the triple aim of reducing costs and improving patient outcomes. And this was their first stab at it. By 2012, it was clear that that change wasn't going to be enough and other changes needed to take place. So the state enacted a law called the SMART Act that implemented an additional $1 billion in cuts statewide. So the state Medicaid office was pretty desperate to change, to decrease costs, but they were also inclined to try new models, which they called care coordination entities, which is similar to an ACO, but not really taking risk. Or at least not taking risk at the beginning. By 2014, though, we had a new administration, changed from Democratic to Republican, and this new administration really had different priorities. And from my point of view, anyway, it seemed like experimentation was out the window. They wanted to move this all much faster and engage in the savings that they hoped could happen much quicker. So by 2016, essentially all patients in Cook County, which is by far the largest county in Illinois, are in managed care arrangements, and well over 50% statewide are also in managed care arrangements. And the state is really looking to these managed care organizations, these MCOs, to achieve the savings that were initially forecast as part of the SMART Act and some of the cost savings set out in 2011. So what is MHN-ACO? MHN stands for Medical Home Network. It was started in 2010 by a private philanthropist in Chicago who was aiming to improve care for women and children. Her goal was somewhat ill-defined. She knew that care coordination wasn't very good for these people, that access to care wasn't very good, and she knew from folks that she had talked to that not only was access not good, but that outcomes weren't necessarily good, and she thought this was a place that she could have an impact. So she got together a pilot group of health centers and hospitals that were interested in working on these issues. And the group started what is called the Medical Home Network. MHN approached the state for a pilot program in 2012 to say, if you can give us some grant money up front, we will work to implement some care coordination activities and some IT activities that we think can have an effect on cost as well as outcomes for our patients. So by the time fee-for-service Medicaid in Illinois moved towards managed care, the MHN was really well positioned to respond to this. And so we applied to the state and became a formal ACO in 2014. So what is the ACO structure? There are 12 owners of the ACO. 9 of them are federally qualified health centers. 3 are local hospitals. The legal structure is an LLC, and we currently have contracts with one payer, which is County Care, which is an MCO that is run by the county government in Cook County, Illinois. We're working towards having a multi-payer program, but currently it is just one payer. There are about 80,000 covered lives in the program, and we do anticipate taking downside risk starting in 2017, though at this stage we have shared savings potential and no downside risk. So how do we hope to achieve some of the outcomes that we're after? The clinical model is really set up on a couple of different key components. One is we insisted that there be practice-level care coordination. So unlike many MCOs, managed care organizations that provide care coordination by nurses sitting downtown or maybe in a far-off state somewhere, our care coordination takes place in the practice, literally sitting next to the physicians and nurse practitioners who work with our patients. The ACO also implemented an IT system that can really support this work. So the IT system receives real-time inpatient and ED alerts from partner hospitals, but not just the 3 partner hospitals, also a large network of hospitals throughout Chicago who have agreed to participate by sharing their data with us. What that data means is that unlike traditional MCOs where we might receive data about inpatient utilization months in arrears, with MHN ACO, we receive real-time data telling us when our patients are signing in at the emergency room or inpatient. The ACO has set up centralized standards for what outcomes they expect to achieve, but performance is decentralized, meaning they don't necessarily dictate exactly how we need to achieve those goals, but the goals are set centrally and by the group who all votes through a governance process. The ACO provides technical assistance to all the practices who are participating. The financial model is new for us. Esperanza is a relatively small organization, as you might imagine, taking risk is scary for us. And participating as part of a larger ACO organization makes that really possible. We receive direct contracts for primary care from County Care, not through the ACO, but the ACO has a contract for care coordination payments. These payments are made up front and are expected to help cover the cost of care coordination and care management for our members. We also receive pay for performance if we meet certain quality metrics at the end of the year. And then finally, we receive shared savings. So if some of these upfront investments, like the care coordination, as well as the costs of primary care and other medical costs, don't exceed the set medical loss ratio, we receive shared savings. And last year, Esperanza actually received $300,000 in shared savings, which for an organization of $13 million is not insignificant. And this is actually only represents about 20% of our patients. So it was a pretty significant savings and allowed us to continue to invest in more changes and improvements to our systems. This is just a flow chart of the financial model. It's probably a little more complicated than some of you need to know, but I think the most important thing is about at the middle of the chart, where it shows that if there is a surplus, part of that surplus is distributed to the owners of the ACO, which include the FQHCs as well as the hospitals. Part of it is kept aside for risk reserves so that when we go to a full risk type of situation in 2017, the ACO can assume some of that risk. And the owners of the organization are less liable for capital calls. And then part of that on the right-hand side is put aside for clinical initiatives and investment. And what that is that the owners of the ACO, the 7 FQHCs, and the 3 hospitals get together on a regular basis and decide what they want to invest this money in order to achieve the outcomes that we're looking for and to really try and innovate. We have had significant outcomes through the ACO. This slide shows what some of those are. We have hired Milliman to look at our costs versus the cost of the entire network. And we know that our costs are 5% lower on a risk-adjusted basis than those of the remainder of the county care network. Our readmissions are also 2% lower at 11% versus 13%, and that's for the Affordable Care Act population, so the adult Medicaid population. On the bottom left, we also know that our utilization for the ACA population is lower, both in terms of inpatient days and ED visits. And this, as well as these other outcomes, really stem from aggressive care coordination, calling people when they show up in the emergency room, educating them about appropriate use of primary care, making sure that handoffs are done on an appropriate basis, screening them for social risks, and then trying to meet those social risks. We do screen all of our patients using a health risk assessment. And as you can see on the bottom right, the ACO has completed risk assessments for about 71% of their patients versus the remainder of the network, which is only 31% complete. So we are doing a better job with patient engagement, and that is helping to lead to some of these better outcomes. So how can you get started with this? I think that I don't have any great insights, but philanthropy was definitely important for us. We did have somebody who was interested, and I think talking to local foundations could be a way to approach this. We also really made creative use of Medicaid payment structures. We talked to Medicaid. Instead of waiting for them to come to us and say they wanted to change systems, we actually went to them and said, listen, we have something we want to try. Would you support us on this? And that was really important for us. And then I think trust is really important. So you have to get trusted partners together, people who you think you can work with. Most health centers aren't in a position to do this work by themselves. And so you have to talk to people who you trust and you think you can work with, and then start to see what you think can really work. A lot of talking has to take place to get these things off the ground, and a lot of planning. The key lessons learned for Esperanza were really that you need to learn to try new things. You can't be afraid of change. Transformation is critical to make these things work. Care coordination, having it in the practice instead of downtown at the ACO level or at the MCO level, was critical for us because it allowed our care coordinators to really become part of our primary care teams. Radical transparency is super important. We report on a monthly basis for all of the members of the ACO how they're doing on the metrics that we've set aside, including inpatient readmissions, numbers of health risk assessments done, number of care plans completed, and so forth. And the fact that everybody can see how everybody else is doing within the group brings out everybody's little competitive edge, and just from that reporting alone, we've seen a lot of improvement. But having the trust there where performers who are not doing so well aren't afraid to put their data out there with people who are doing much better is really important because it allows people to share best practices. So mutual trust is incredibly important. Mutual accountability is also important. We do have the ability to kick people out of the ACO if they're not performing. We've only been around for a couple of years, so we haven't had to do that yet. But we have had some pretty serious conversations with members to say, we need to step up to the plate. And I think that the people see the potential in that, and they see the risk in not participating in the ACO. And so we've had very good success with that so far. I think with that, I'm going to turn it over to our next presenter. Is Rich there?
Yes, I'm here. Good morning. I was about to say good morning, everyone, because here in Hawaii it's 8:30 or 9 now, but I'll say good afternoon. My first slide up on the screen, I want to have you look at the title, because I think it's significant in what we've come up with in Hawaii. And it's about accountable communities, and it starts with that. So much of my presentation this morning is going to be where are we now and how are we moving forward. But I just want to spend a minute and say where we came from. And we've been working on payment reform for about 10 years, but doing it through community boards and consumers. And, this dates back to the old Pay for Performance summits and things that happened 10 years ago, where it was obvious that healthcare costs were rising much too fast. The business community was well aware of the impact on the economy. And basically, performance-based and value-based healthcare, the foundation was being laid. And so, a few years after that, a couple years after that, NCQA started talking about health homes, and there was the beginning talk about performance-based metrics. And so we spent 5 years doing a number of conferences that engaged about 30 health centers across the country in taking a look at this, at payment reform, and saying, what is missing from the model? Will we be fairly valued, and how will we be empowered by this process? And what we came up with was the idea that we needed to be engaged in accountable care. And we're starting to look and wait for government to come out with guidelines to how to form an ACO, and we started waiting for our state to do something. And I had a talk with one of the health plan directors, and they told me, you really don't need to wait for this. You can partner with other entities that are licensed to do these sort of things and start your own, quote, virtual ACO. So we, as a part of payment reform in Hawaii, where we were one of the 11-15 waiver states, that moved, back in around 94 or so, moved Medicaid into managed care anyway, and we had 4 predominant health plans in the state. And the health centers in Hawaii had already started their own managed care organization, but it was really another health plan that we started working with on an ACO model. So that's where this came from, and today it remains the concept of it's about community, and that's what health centers are about. And how do we make our community more proficient, more effective in getting more value out of the healthcare dollars? So I just wanted to lay that foundation. I'm going to go for an arrow click here, and let's see if we can get this to move. Here we go. So what is it we came up with, and what is it that the model is based on? And we decided that we wanted to be an equal partner. We wanted an accountable care organization, but we realized we couldn't do everything ourselves if we wanted to get to where we wanted to go quickly. And so we looked around for the best partners, and it could have been a hospital, it could have been, an HCCN, or it could have been a lot of things. But what we ended up with is the idea, our best bet was to partner with health plans. And one of the things is, as we started looking and assuming where the preventable costs were, and we began to realize that the kind of transformation that would empower us was the movement of, services that are provided in hospital ERs or in hospitals, moving those to the community level at a less expensive level of care was where we wanted to go. And we realized the aligned incentive we would have with health plans to do that. So that was fundamental. And we started setting up a methodology for measuring where the preventable costs were in healthcare. And we did it in partnership with the plans. We realized we would not get anywhere if we did not build a couple of really important capabilities. And one was our own community-based care coordination and really solid health information technology. And we didn't want the plans to provide this for us. We didn't want 4 sets of care coordinators, 4 different gap analysis tools and population management tools and predictive analytic tools being given to us. We wanted to develop it. And again, it's a part of empowering community. We knew we had to shift from a medical model to a healthcare model. And we recognized that a lot of what health centers do is not recognized by health plans or payers, because basically a lot of them are non-reimbursable services. So what we needed to do was to start codifying and tracking everything we do. And we've been doing that for a long time. And then we wanted to make sure that we didn't want to lose our roots, that patients and community needed to be a part of this. And also, way too much emphasis was being placed on evaluating the performance of primary care providers without looking at the performance of health plans and the state and others along the continuum of a system that produces outcomes. So, and then fundamental to this was to share any margins that were created in risk pools, and risk pools were specific to providers, to health centers, and to divide those up based on the relative utility that the plan and or the health center would provide. And one of the goals was, and by the way, we did not get any, we did not seek authority from any government, not the state, no one. This was a business transaction with the health plans. And therefore, we sought no additional money from the state. The mission was to get more value out of the dollars already allocated from the state. And I think that's one of the reasons we're not on the map. We're not on the map because this is not a state initiative. Okay, so let's move the arrow here. I'm going to boil it down to a few really important aspects. And one is that the health center is responsible for the total cost of care for all patients fairly attributed to them. So that not only are we looking and not only do we have data on all of the utilization and expense data, the medical loss data for what happens within the health center scope of service, we also have the data and we're responsible for costs such as hospital care and pharmacy care and everything. So that's a really important fundamental principle that every health center needs to think about. At what level do you want to be a player? And do you want to accept the responsibility of the total cost of care of your patients? I think that's very important. The key aspect of this is to try to then systematically, in partnership with plans, manage your risk pool together and share in any savings created. After we looked over a number of years at the preventable costs that we could impact on, and there are other preventable costs that out there, such as pharmacy costs related to generic drug use and so forth. We're already really good at that, over 90%. So rather than look at that, we started looking at those things that we felt we could impact on. And that included the inpatient care transitions, particularly for complex patients, and hospital-based emergency department visits and high utilizers, and and to manage the high-risk cohort, as I mentioned, and advanced directives. We also wanted to find a way to incorporate social determinants of health into this model, because we believe, and if you look at the things that are sometimes below the radar that health centers do, they have the opportunity to have a huge impact on the social determinants of health. So we started off by, when we created margins, to be capitated for performance metrics and standards related to social determinants of health. And initially, and to a certain extent we still do this, they're parallel to the NCQA standards. We just created additional standards in 4 areas related to the social determinants of health. So where are we going from here? We're very, very close now to integrating 4 or 5 health centers, clinically integrating, so we can negotiate as a network. And again, this is happening independent of any federal or state funding. It's something that we're doing on our own. And like I say, we've now acquired a population management tool that will allow us to clinically integrate. So that's the framework. And as I look at some of the APM models that are out there, the alternative models that are state-based initiatives, I would ask people to ask the following questions. One is that quite often they make the assumption that volume is the problem, that you have to reduce primary care volume in order to achieve payment reform, and so the target is PPS. We're finding that's not the case. And in many cases, if you want to address preventable costs, you have to increase primary care volume. There's some focus on health centers on the total cost of care. Let me repeat that. I'm going to revisit the comment I made earlier. Do some of the APMs motivate health centers to look at the total cost of care? Because I think that's a very big part of the aligned incentives that need to be in place. I don't know of much evidence coming out of some states yet that show that APMs really, some of the ones that are state-based and on the books right now, are producing huge dollar savings. I mean, I think it's a question we have to be more critical of. Some assume that they are catalysts to alternative touches, and I think there's limited evidence on that. And I have some evidence on what we're doing in terms of alternative touches and how reducing volume-based payments and moving to capitation may not be the impetus needed to grow alternative touches. And I think as we look at APMs, everyone needs to do a baseline of how their current PPS system is working. We have some health centers that haven't had a change of scope or a rate change under PPS in 10 years. And if that's the case, alternative payment models may look more attractive. So we all need to assess where we are on that. One of the ways we've defended PPS is to basically take a look at how costs are allocated in the PPS rate construction. And if you look at a typical doctor's visit to a primary care visit to an outpatient clinic or a private practice, that's really only half of our PPS rate construction. So if we were just paid for that, our PPS rate would be, or our payment rate, volume-based rate would be 50% of our PPS rate. But we provide specialty medicine. We're open extended hours. We have 24-hour access to urgent care, lab, radiology. We offer a bundle of specialty services, and part of the alternative touches is factored into the rate computation. So I think we need to defend and acknowledge what value we provide for our current PPS rate. So let me get into the nuts and bolts here in the last few minutes of how we actually operate this. Part of the contract with health plans is that they give us a capitation, but it's not applied to the medical loss ratio. It's an administrative capitation for HIT care coordination that we match. And annually, we come up with a work plan for HIT and care coordination, and the total is well over $1 million. We hire care coordinators that target the performance metrics we have on total cost of care. And one of the most promising is the low acuity ER visits and bringing that down. So whenever someone comes out of a hospital, we get a data feed from the hospital that they're our patient in the emergency department. We send our care coordinators either in person or on the phone to interview the patient, and we do this survey, and it's up on the screen now to determine why they use the emergency room. And this is very preliminary. We want to refine this. But if you look at the reasons that people go to hospital emergency rooms for low acuity visits, and there's a lot of low acuity visits, the main reason is there's no other access to care, and their clinic is either not open, or they may not know who their primary care provider is. But there's a fundamental link to access to primary care here, and so that's very promising, because the cost of these ER visits are well over $2,000 a visit. The PPS rate is less than 10% of that, so we have hidden value that we can get at. Moving forward, we are now studying with health plans the differential between our costs for ER visits and the cost for the aggregate cost for the Medicaid plan. And you can see a huge differential for our risk pool compared to the aggregate. And one of the things we've done, in addition to care coordination, is realizing that health centers opening evening hours, and we've opened 3 now. The 3 of our clinics are open well into the evening to basically guide people to less expensive urgent care or primary care instead of going to the hospital. And so that's been a huge factor. Now, what are the things that we've seen in the evening in a basic health center practice that we've diverted from hospital ERs? And here's a breakout. This is just for Medicaid patients in 1 calendar year. Somebody needs to run the numbers on this. If there were 5,779 visits for which the health plan risk pool paid 1/10 of the cost for, we're getting into a really good return on investment for health plans investing in us. In addition to this, one of the things that's been put out there as a value of some of the APMs is that if you are capitated, you will have more money to do alternative touches. There was a period in our history where we were capitated, fully capitated, took downside risk, had no PPS or cost-based payment. And that was a time when I had to shrink some of the services that led to alternative touches. Now, under the model we have now, in 1 year, we had close to 25,000 alternative touches, for our patients. So how important is patient attribution? And this is a huge issue we're dealing with now, because what happens is you're responsible for all patients assigned to your risk pool, regardless of whether you've ever seen them or not. So we were, for a few years there, and we've been doing this model now for 5 or 6 years, we were hitting about 2.2 million of gain share in aggregate for 4 health plans. And that certainly made it worthwhile and incentivized us to open later in the afternoon and into the evening and open more primary care clinics and improve access, because we got a return on investment on the back end. Those 2 years of losses really concerned us, so we started, one of the keys, absolute keys to this is that we have signed data agreements with the health plans that they must disclose where every single dollar goes for our patients, even if it's for hospital and services that we don't provide. And there's a format in that data agreement, how timely it needs to be. So we went back and started running the numbers on the data for those years in which we lost money. It was eye-opening. There were about 10 cases accounted for $9 million of loss. All of them, almost all of them, were newborn babies for which we'd never seen the parents. In some cases, they weren't even in our service area. So we started looking at how the game is played. And quite often, an uninsured patient delivering a baby may show up at a hospital, and they find a way to get them into Medicaid. There's an algorithm that assigns them to a plan, and that plan has an algorithm that assigns them to a health center or a risk pool. And so a huge amount of patients were being retroactively enrolled and attributed to us. Now, that has changed in the last year, and we have a new Medicaid director, and I think there are controls now on attribution and retroactive enrollment. But the reason I make this point is that you've got to have the data. If you don't control the data on the total cost of care and you're not a player in that, you could easily become a victim. Okay, wrapping it up here. It's interesting to look at the 15 health centers in Hawaii, and for one plan, who's losing money and who isn't losing money on a per patient per month basis. And there are 2 health centers, and predominantly one, that loses a huge amount of money. And guess what? It's the homeless provider. And so social determinant factors and the lack of adequate risk management and risk adjustment, I should say risk adjustment, is a key long-term factor here. If we're going to level the playing field and truly incentivize health centers to look at the total cost of care, we got to look at social factors and risk adjustment. So where do we go from here? Wrapping up, I think all of us need to really resolve this volume to value issue. By us expanding hours, we're growing volume, but we're also reducing preventable costs. We need to evaluate all involved in the healthcare continuum of care, not just the politically vulnerable FQs. I think you need to look at hospitals. I think you need to look at the proficiency of health plans, and you'll find some of them are much more proficient than others. And I think you have to look at state government and their Medicaid programs. By tweaking the Medicaid programs, you may get more value than you do by focusing on FQs.
Do you want to do your voting?
And finally, rediscover our FQHC roots. And that means that we look at the value-added services we provide that are currently below the radar, and here's a few of them, and how do we incorporate them into the payment model? Thanks. Finished.
Wonderful. Thank you so much to both Dan and Rich. This was really great to get a little bit of a glimpse inside your organizations, your ACOs, and some of the experiences and challenges you've overcome. We're going to throw it now to Jason Fournier. He's CEO of the Westside Community Health Services, FQHC in St. Paul, Minnesota, and also chair of the FQHC Urban Health Network, or FUN, one of the earliest Medicaid ACOs. We are going to be swapping out slides here in a second, so there may be a little bit of a delay on the webinar, but Jason has a lot of experience over the years looking at his ACO and others, and so we're excited to have him give some reaction and perspective on payment reform for FQHCs more broadly and where we think things may be headed. Jason?
Thanks so much, Mac. Good afternoon, everyone, and to those in Hawaii and elsewhere where it's still morning, good morning. Just a point of correction, Mac, I'm actually currently the board treasurer for FUN, immediate past chairperson for FUN. I was the board chair for 4 years, and now I'm on the money side, which I think a lot of the FQHCs on the phone and others listening can hear. So I want to compliment both Dan and Rich on their excellent presentations this afternoon. Very thought-provoking, 2 very disparate models that are evolving, which I think is very similar to what's occurring across the country. As Dawn kind of teed it up for us, just kind of thinking about the one slide she had represented, there's multiple states that have been very progressive, Oregon, Minnesota, other states that are very progressively thinking about accountable care organizations and all alternative payment methodologies. And beyond that, as Don had indicated, there's a lot of movement occurring more recently within the FQHC sphere thinking about this, but also coupled to that, just like Rich had outlined, organizations like his that have been engaged in this activity for very, very many years. And so compliment them both on providing excellent presentations to us. So as an individual sitting on the phone right now and knowing the audience, or anticipating the audience on the phone right now, I'm sure, like we all have at some point, have thought about, okay, what's the next phase of evolution for my community health center? What should I be thinking about? And so one of the things, of course, is really thinking about how do you and why should you engage in payment reform initiatives? And that will vary depending on what your individual construct in your marketplace is. variabilities within that marketplace. Who are the players? Are the players the Medicaid agency? Is it the health plans? Do you have managed care organizations that are willing to play? And if you're more on the rural side, what does that mean from a Medicare perspective and perhaps shared savings? And so our intent this afternoon is really just to go ahead and engage in some discussion and provoke some thought as to what are some of the things you might be thinking about, perhaps already are thinking about. So when we look, the slide that you're seeing up in front of you right now on the screen is really just taking a look at why should you even think about it. And really, we experience this as individual F2HCs serving our patients each and every day. And so depending on your market, the level of fragmentation that you're seeing on the screen will vary, but for most of us, we still continue to experience as community health centers a fragmented system, a patchwork of system in which providers are willing to accept Medicaid, let alone our uninsured patients. And so these disparate systems then lead to challenges as it relates to care coordination and management. And what access to data do you have that informs your clinicians and you as an individual F2HC in engaging in care coordination activities and case management, care management initiatives that would better the health of the populations and communities that we're serving, which as both Dan and Rich alluded to, have challenges, as we are very much aware of, as it relates to social determinants of health and how do they play into the overall approach to how healthcare is being delivered. And so one of the main reasons, in my experience, is really that F2HCs, we really just have the necessary primary care experience. We've been doing this for over 50 years as a group of organizations across the country. Resources vary. Of course, we've done it very effectively over the last 50 years, in many cases being under-resourced. And so the real opportunity is to take that expertise, build on it, look at how we strengthen the services, enabling services, care coordination services, and then really look at how do we activate our patients differently given the information that could potentially come through a payment reform initiative and the APM. I've got bolded here primary care focus. I think unlike so many other organizations that are contemplating how do I play under MACRA and how do I play under incentives that are emerging, F2HCs, we have, as F2HCs have a unique perspective is that our main goal is really looking at primary care, so we don't have that inherent conflict that occurs in these large integrated systems where you've got to worry about, well, geez, if I lower emergency room use, then I'm going to end up robbing myself as it relates to a potential cost center. And so placing that patient in the middle is always what we've done well and continue to do. So advancing to the next slide here, thinking about it from your own organization, or maybe you represent a group of community health centers as a primary care association or beyond that, what are some of the motivators that we all should be thinking about as it relates to why would an F2HC even contemplate, or a group of F2HCs contemplate engaging in payment reform? And the way I like to think about this is really thinking about it from both an extrinsic perspective and intrinsic. And of course, those motivators are going to be intertwined, and in some cases you have both. But, if your marketplace is anything like the marketplace that I experience here in the Twin Cities and colleagues that I have in Chicago and in Michigan and elsewhere within the country, you're going to be experiencing increased competition for your patients. As more and more of our patients have become insured, systems across the nation are looking at ways to go ahead and gain access to those patients. And frankly, community health centers, F2HCs, we're moving from really having been the default provider for so many of our communities and patients to really having to make this transition to a provider of choice. And what does that mean, and how do you engage in that? So that increased competition is there. We also have increasingly irritated payers, be that the Medicaid agencies who across the country, in some cases, believe that F2HCs, unfortunate for their perspective, believe that we're overpaid. And that necessarily isn't the case. And Rich certainly was pointing out the ramifications of really the angst that gets put around with Medicaid agencies as it relates to our PPS overall in terms of the rates. And then when we take a look at payers are also concerned with relatively weak clinical outcomes. And of course, one of the challenges is, as both Rich and Dan alluded to as well, was the fact that those outcomes, just like on the financial side, aren't always risk adjusted to take in those socioeconomic demographic attributes of our patients that could influence more adversely the outcomes that are achievable within our settings and within the communities we serve. So those are some of the extrinsic motivators. Intrinsic motivators are really, as the landscape of healthcare within your marketplace is changing, and that's going to vary if you're urban or rural. FQHC a little bit different. Rural, maybe you're the only game in town, or urban, a lot more pressure potentially. But the challenges in rurality is very different than in urban in terms of your ability to recruit workforce. And so when you take a look at how do you stay relevant in a changing and challenging marketplace, I should say place, not plan. And also when you take a look at this, one of the other intrinsic motivators is how do you gain access to resources that you need for the patients and communities you serve, and how do you look at delivering healthcare differently? And I think that's important, that care transformation model. And I think those atypical touches, as Rich was alluded to, is something that's value added, which all too often doesn't get accounted for within the payment systems. And so what does that look like moving forward, and how might you create a service and a system of care that better connects and motivates and engages our patient populations? The other is a strong desire as community health centers to not only address and treat the disparities that are adversely impacting, the health disparities adversely impacting our patients, but also the desire to move more upstream and look at how we engage in inequity and really what resources could be brought to bear relative to that. And then finally, an intrinsic motivator, doesn't matter which FQHC colleague I'm speaking to who's in the know across the country, there's this undercurrent of concerns about, well, is PPS going to persist? How long is PPS going to persist? And so those are some of the questions. Well, I believe that PPS is going to persist for the foreseeable future. I think it makes sense for us to be thinking about how do you go ahead as an individual FQHC entity, position yourself to be successful into the future as well. And of course, there's both extrinsic and intrinsic motivators that come back. And so one of them is both for better patient management and engagement of our patient populations is through payment methodologies and reform, you can leverage in data that you might not have access to otherwise. For example, fund partners with the state of Minnesota, and we have access to claims data that we run through very robust analytics that we've developed over the last 4 or 5 years that allow us direct access to information that we didn't have access to before, thereby allowing us to engage our patients more proactively into their care. And so that's one of the reasons. I've already mentioned the financial constraints. And then service delivery constraints is, how do you create a model that allows us as individual FQHCs to be more successful within that marketplace? So a lot of key motivators here. And so when you think about this, what is payment reform about? So if I talk with my medical director or my chief medical officer or dental director, their interest is really not so much about the payment side, while they get that that's core to the mission that we have as an organization and as an FQHC. It's really about how can we provide greater value, not necessarily to the payer side of the system, but more importantly to the consumers, our patients. And so this slide here just kind of outlines where most of us as FQHCs are sitting. And so on the far left, you'll see that's the far left, and the arrow pointing up is really about the quality engagement that's seen within healthcare. And you see fee-for-service, which is where most of us as FQHCs reside right now. And when we take a look at that, that's really our prospective payment system and whatever payment methodology happens to be in place in your state relative to community health centers. And then you can see the spectrum. Of course, a lot of community health centers live and breathe within P4P as well, pay for performance. Very few, if any, are involved in bundled payments, although having just listened to Rich, what they're doing with the health plans in Hawaii is quite interesting. I don't believe it falls into bundled payments necessarily, but it's a very interesting capitated arrangement they've had in the past and some new things that they've got going on. As we heard from Dan, the ability to share in savings right now is what they're doing through their program at MHN. ACO out of Chicago, which is very interesting, very similar to what we're doing here in Minnesota with Fawn. And then very few, if any, are taking downside risk, and Rich's is a good example of that. And then when we take a look at global capitation with full downside risk, I'm not aware of any FQHC that's done that overall. So you can see the spectrum, but the further you move right on this particular slide, the greater the maturation on the payment model, as well as the ability to transform care delivery, because you have greater control. But with greater control over the delivery and the monies comes risk. And so that's one of the things that I think all of us, as we're thinking about this, are trying to figure out a little bit more. So this next slide, just kind of, if you're feeling a little bit overwhelmed, you're in good company. I remember as we were thinking about this as a group of 10 FQHCs here in the Metro Twin Cities back in 2011, what's an ACO? Why should we even consider this? Your mind spins, and having been immersed in this for the last 4.5+ years now, my mind still swims a little bit as it relates to thinking about payment reform initiatives. And I think the key to this, when you look at the slide, is there's a lot of different options, and there's more that could be represented beyond this slide. The further you go up on the slide towards the top of the slide, or the further you go to the right, you increase collaboration and you look at optimizing outcomes. And at the end of the day, I think that's a prime motivator for us as a collection of community health centers across the country to engage in payment reform, because it allows us to tell our story about why FQHCs are so effective. And so when we take a look at that, it's very much key for us to contemplate what payment reform initiatives are viable given our limited constraints, how I might position my organization to be successful as an FQHC within my individual marketplace. Of course, with that comes barriers to engaging, right? And so one of the main ones that I hear from providers from other FQHCs, and that is, well, this is just about shifting the risk from the MCOs to providers and without any associated resources. And so I think as you contemplate, and maybe you're contemplating, maybe you're full on with ACO constructs and payment reform, ABMs in your state, thinking about what resources do you want to gain? What is your end result or objective that you'd like to go ahead? One of the things that we found, which is very helpful and useful, is really taking a look at the duplicative efforts that are occurring between the MCOs and us as individual FQHCs, and trying to figure out, okay, how do we go ahead and get the resource where they're best utilized, where they can best serve our patients and communities. And frankly, I believe very strongly that proximity to the patient is of key importance. And so a care manager or care coordinator who's not proximal to that patient, i.e. not in the primary care service setting or immediately immersed in the community, is not going to be as effective. And I think that's extremely important as you start thinking about ways to go ahead and bring those care management, care coordination resources in. And what does it mean then? What are the barriers to activating your patients into their health differently than in the past? And what does the care coordination structure look like? Again, mindful of the fact that many states right now aren't even recognizing that. The other concern that I would have and have continue to have, and I think is a barrier for us as FQHCs in engaging in this, is the view when it's payment reform only, it can be short-sighted. And so how do you engage in discussions with your state to say, you know what, we want to do something innovative, but perhaps a 12-month period isn't enough. And of course, that's how most of the payment models are looking at it. Rich alluded to attribution. I agree with him wholeheartedly. Attribution is key. The other is emphasis on looking at it from a population health perspective. An initiative that you try today may take 2 or 3 years to go ahead and reap benefits. And so that's something to think about how you engage the stakeholders that you're thinking about talking to. Another barrier is, do you have the technical wherewithal within the group to do this? What analytic resources do you need? Because data does drive a lot of the initiatives. When you have the data, it helps steer it. The end result is that data is only going to take you as far as the care transformation initiatives that you have and are laying out there. But there's a lot of great opportunity out there. And I think, again, community health centers are uniquely positioned to go ahead and effectuate this change through the primary care emphasis that we have. Of course, one of the things to take a look at is the ability to enter into these arrangements require a significant upfront investment, and that upfront investment could be a high entry. And I thought it was very interesting to learn from Dan that one of the ways that they got this kickstart in Chicago, which kudos to them, is just they were able to work with a philanthropist who was willing to go ahead and engage. And I think those learnings are important. In order to get started, that was one of the things that we learned here in the Twin Cities, is that upfront investment is the biggest hurdle to get over. Once you've got over it and you're starting to go through some transformation, the next is really going ahead and addressing the change management aspect of this. As you're navigating between a value-based a volume-based to value-based perspective, there's concerns that it's not going to work. So I think that's the reality of it. And then the final slide here is just one where you're really thinking about, well, how do I get to tomorrow when today is, very secure, very safe? How do I navigate this path? For us as F2HCs, it's very tricky. And so I've got to have one foot in the present, the reality of PPS and what's going on, and I'm thinking about how do I transition into a value-based payment reform, alternative payment methodology, and how do I make that transition? And so we don't necessarily have a playbook for you today, but this is really intended to go and provoke thought about what potentially could occur, and Dan and Rich have really outlined some two good examples of the successes that Brethren F2HCs from across the country are engaged in. And so at this point in time, we're going to go ahead and open it up to questions. And so I'm going to turn it back to the folks at SNAC to go ahead and at least get us started with that. As we start seeing questions come through, they're going to send them my way. So. Mac?
Wonderful. Thank you very much, Jason. So we have now a nice chunk of time that we've set aside to make sure that we're able to answer all of your questions. Feel free to type in the questions in the chat box. We can direct them to one presenter in particular or just broadly, and we can all of us can chime in. If you have more general comments, those are very welcome as well. Really, the purpose of this section is just to make sure that we're able to have a nice back and forth to get the issues covered that you're interested in.
Yeah, and Mac, maybe I'll go ahead as you guys are ramping up here a little bit, kind of throw out the first question to Dan and to Rich. And Rich, you kind of alluded to this, and I agree very much. Relative to social determinants of health, I agree very much that it's a key long-term factor that has to be accounted for. And so when we talk about risk adjustment, and just curious in terms of both from your perspective, Rich and Dan, how you guys have been able to have that conversation with your stakeholders, and in particular the plan and or as a collective group with the MHN, the Medical Home Network, ACO in Chicago, how you've had that conversation with your stakeholders in terms of, as F2HCs, yes, this is a Medicaid program, but more potentially more uniquely challenged because our patients come in with higher linguistic needs or cultural needs. Dan, in your case, serving a very large Latino population. So just your reactions to that as we're getting some questions in here, guys.
Well, I think we're a ways off from expecting actuaries to verify social determinant factors as it influences risk pool allocation. In the series of conferences that we had that I mentioned, we went through 5 years of conferences in which the majority of the participants were health center consumers. As a part of this process, we actually sent a team to CMS years ago, and we asked them, who's doing the most compelling research on social determinant factors as it relates to risk adjustment? And they pointed us in the direction of San Diego and a gentleman there and a researcher, and we brought him in for a number of conferences and for a couple of our conferences. And so that let us know that there's substance there that needs to be explored. However, we're a little ways away from getting, the actuaries to acknowledge it. So what are the interim steps to build a foundation for that? And, there's probably three. One is in the exchange and in the business relationship with a health plan, we said if we show progress on preventable costs, will you continue to fund initiatives in 4 areas related to social determinants? And so we worked that into an agreement that if we show progress in one area, they'll invest in issues like workforce development, areas of cultural proficiency. We're the largest provider of primary care to Native Hawaiians. So a big part of what we need to do is integrate traditional practice into our model. So we've been able to support some of that through capitation, and it really is in the form of quality standards where we show improvement on cultural proficiency. So it may be related to increasing the number of our physicians that have been trained through a cultural training program or whatever. The second area that we've been involved in is recognizing that we're going to need a formal way of assessing the social determinant needs of our patients. So we've been a player in this PREPARE project that NAC is involved in, and we're one of the 4 sites, and I think Chicago is a site as well. And so what we've done is we've taken that assessment tool where you look at social needs, and we've added a risk stratification tool to that through Altruista. So we've actually worked with a group to put a risk score on that. And so that care coordinators would be empowered to know what is the risk to families for social factors. The third thing we have done is United Healthcare has applied for a CMS grant under Accountable Community Project through CMS. And they came to us and wanted us to be a partner in that, to form a bridge agency to bring in the social services, to apply a standard assessment tool and start integrating that into the Medicaid model, but with the potential of having supplemental payment through feds and state to support homelessness initiatives and food and so forth. And what we said is that we won't be a part of, we won't be reporting to you as a bridge agency, but we wouldn't mind partnering with you and forming a bridge agency for the west side of Oahu, where we will then contract with the social service providers to form a network. We will co-administer and gather data from the assessment tool. So those 3 things that we see as promising, and I do think it's a very much a part of the future, is accountable communities and the integration of social determinants of health factors into the risk model.
Thanks so much for that, Rich. Dan, anything to add from your perspective?
No, I think we're really just beginning to look at that with MHN. There has been some discussion of particularly African-American birth outcomes being a heavy cost to bear in the system and how that might affect payments. But I think that at this stage, we're still all for one and one for all, and that's been sort of an important part of our model. We are lucky because we don't have any significant outliers in our group, like a homeless provider or a migrant health provider, which I think really would change things dramatically.
Well, thanks for that, Dan. So another question here is just for both you, Dan, and Rich. Just kind of contemplating these external partners, then can you talk about strategies to, the strategies that you've developed or potential strategies that you would suggest to those contemplating this in terms of how you develop and sustain relationships with trusted external partners? What does that look like in terms of engaging in these conversations from your perspective?
So at Esperanza, we, and with MHN, we really rely on the individual members of the ACO to develop the relationships in their neighborhoods that will really lead to better outcomes. And that's actually been one of the strengths of the ACO and one of the reasons why we insisted on decentralized care coordination, because we feel that if the care coordinators are located in the community, they'll be best prepared to know about community resources that can really help patients meet their individual goals. I think we haven't really taken that to the next level. Our social service partners are really doing this work with us out of the goodness of their hearts, because it is their mission, and they're looking for clients, and of course they have separate payment structures. But I think that that is an interesting thing to look at going forward, where we're getting the most bang for buck and how we can really push the needle forward, and whether there are ways to explore potential financial partnerships with those partners. But we haven't gotten there yet.
Rich, anything to add from your perspective in terms of that engagement with external stakeholders?
Well,
in terms of strategies, specifically. Sorry.
I think the fundamental relationship is you have to find a partner that has capital, is well positioned in the market to be a partner, so that they complement what you can offer. You know, health centers don't have a lot of capital. They don't have a lot of reserves. There's a lot of them that barely make payroll. And so I would look, first of all, look at the issue of aligned incentives. A system works best when the component parts are all focusing on the same aligned incentives. And what we saw in choosing the health plan is that they basically want to save money. They want to get more value, but they're really good at, some of them, at, focusing on reducing costs that may be unnecessary. So how do we complement them? And one of the mantras that we have always repeated here is that you have to prove the value of what you do, so that if you weren't around as a health center, it's going to cost somebody a whole lot more money. And I hate to bring it down to the dollar factor, but I really think that is so important. People realize that if we weren't here, it's going to cost somebody a lot of money. Now, how do you leverage a relationship so that you are well positioned and you're fair, you're fairly treated with incentives and so forth? And there's a fundamental question every health center has to ask, and that is, how loyal are your patients? If they had a choice of going to any provider, would they choose you? And the reason I think that's a factor is I've had to face off with health plans where I said, I'm sorry, I'm not going to sign with you. And the outcome of that was thousands of patients changing health plans so that they could come to our health center. And so we're really in a situation of finding the right partners. And then the real value is, if you didn't exist, is there an alternative? And in some cases there isn't. And then would your patients choose you? And so I think that gets a little bit at your question.
No, I greatly appreciate that, Rich. I think, it comes back a little bit to what I had mentioned at the outset of just kind of kicking off the discussion is that for many F2HCs, and I do think that you're absolutely right, is we need to view this as, for many years, we're default providers within the community. Our patients, many of which would choose to come to us, but with the transition in payer mix becoming more and more, with folks becoming more and more insured, are you a provider of choice, and what does that mean? And then if you are, you can leverage that in these discussions with external stakeholders, and I think it would be very, very, it's something really that can position you well in those conversations. I also think that you guys are very much spot on in terms of thinking about, Rich, you mentioned upfront investment, and I think that's probably the thing that's most daunting to F2HCs as you start thinking about that. So what are some of the ways to go ahead and do that? And you alluded to them. One is you can find a partner out there and identify the partner and figure out how do you actually get that upfront investment, because so many of us as F2HCs out there really just don't have the resources to be able to move forward without leveraging in some financial means and other means, technical needs, data analytic capabilities into the mix. And so those partners could be a plan or several plans within your community to think about it. It could be your state Medicaid agency. What Dan was able to do in Chicago was to go ahead, that group in MHN was able to go ahead and work with a philanthropist, but also then go ahead in other states, like in Oregon, where they're drawing folks into and having the state go ahead and invest in some of the upfront as it relates to looking at a PM for them, or taking a look at other ways. So you can leverage in your relationship potentially with the state in those conversations and say, hey, we want to try something different here, but this is a little bit uncomfortable, and in order for us to be able to move forward, we really need to have a buffer, especially as you're starting to ramp up. Some of you on the call may know that one of the ways that FUN was able to do it, the group of 10 here in the Twin Cities, we were able to work with a major health plan. It happened to be United Health Group and United Healthcare, and more specifically their data analytics system, wherein we were able to work with them in partnership through our agreement to go ahead and have them front up some of the significant costs into the development of our infrastructure. And of course, with the back end of it being, they were able to reap the benefit when we achieved our results, which we did. And so, you know, from their perspective, I think they would report that it was a sound investment, but leveraging those partnerships in is extremely important.
Yeah, I think I can remember very well a negotiation, a meeting across the table from a very large health plan in Hawaii, and I put on the table, look, we will work with you to address preventable costs. You tell us the metrics. We'll agree to them, and we'll refine the metrics as we go. But you put up $5 per patient per month. And we did this for all the plans, and we have over 20,000 Medicaid patients at this health center. So we're talking real money. And I said, if you put up $5 PMPM, I'll put up $5 PMPM. I will give you a work plan that you can agree on, how we're going to invest in care coordination and HIT, and how we're going to basically go after and the preventable cost and manage the patients at the community level at a much more effective level. And I said, give me 2 years. And at the end of the 2 years, if you don't think there's a return on investment to you, don't give us any more money. And it was a business deal. And so what we had to do was really deliver. And from that, I think the plan's got a return on investment. And one thing to think about is that I believe that health centers often have some of the most complex patients. Many of our patients have comorbidities to depression and substance abuse, but guess what? The greatest amount of preventable cost is in those patients. These are patients that sometimes are using ERs 40 times a year. These are patients that private docs don't want to see. And so the plans will see dollar signs if you are effectively managing the care of those patients and you can prove the value of what you're doing. So we're able to return an investment to the health plan. And I think those are the dynamics that led to the working capital we needed to do what we needed to do.
Rich, thank you so much for that. I think, kind of piggybacking off of that, there's a question here for you. So, as an F2HC sitting on the call webinar today, looking at your presentation and listening to you, one of the things that I might be a little hesitant is that during your presentation, you mentioned a loss over several years that had occurred, and that would be something that I might flag as being very concerning and daunting and deflating. And so when you look at that, how did you address that amongst the group in terms of to overcome that? Because when we start talking about moving beyond what's comfortable for us as an F2HC, in that, we provide an encounter, it's a widget, we get X amount of dollars, it's a comfortable financial model. When we start talking about taking on some potential risk and overcoming, and then it's the same question to you, Dan, is how do you get comfortable with that risk across the table as you're talking about that?
Okay, I'll respond first. And we take no downside risk. So if the risk pool loses money, the plan absorbs the loss. Now, how are we able to do that? I often see these national models where there's a continuum of transformation where the end results in taking risk. You see, I see taking risk as a utility related to a whole bunch of other utilities. And I think that taking risk is worth about 40%, and it's just an arbitrary number, of the gain. And so whoever takes risk should be entitled to more upside gain, but it's not it's not necessary. I think some health centers don't need to take risk. We don't take any downside risk. For us, it was a loss opportunity because I think patients were unfairly attributed to our risk pool. One of the other things we did with our model, and it's called the HARO, and if you're interested, aharo.net is a website that describes some of this, is we wanted to make sure that some of the health centers in our network that are buying into this model are new starts, smaller health centers, and health centers that don't have any capital, so that this would work in other markets and with other health centers. So there's sort of a sliding needle that the more you take on in the way of the utility involved, whether it's the care coordination or a wider scope of services that you provide directly, or the more, like for us, we're now putting together our own specialty network. Perhaps that reflects on how much upside potential you have. So bottom line, we take no downside risk.
And Dan, in your situation, given the 7 FQHCs and the 3 hospitals around, how does that play out for you at MHN?
So we were not in a risk-bearing situation for the first 2 years, so we had a ramp-up period where we agreed with the plan that we wouldn't take risk. And during that time, we put aside a set percentage of our shared savings in order to address future risk. So I believe that percentage was 25%. So it's a pretty large amount. Am I completely comfortable with this? No, I'm not, because going forward there could be a capital call to the organization, to the ACO, which would mean that the owners would either have to put in money or have their ownership in the ACO diluted. So we internally have decided to also put aside some of the shared savings that we've generated in the first couple of years in order to make sure that we would be well prepared to meet such an eventuality. But it certainly is something that's new for us, and as one of the smaller health centers in the ACO, I think we had to be very circumspect about that and make sure, again, that we trusted our partners that they were going to do the right thing and really work towards the end goal, which is better outcomes, and not just sort of take some of the upfront investments and run with that money without actually trying to do the hard work to improve outcomes.
Oh, no, that's a great perspective, Dan and Rich, and I think, some real food for thought for folks as you're contemplating what this might look as you're thinking about alternative methodologies within your own state as it relates to the Medicaid program specifically. And so, question for you, Dan, given the relationship with the managed care organization within the Chicago area, wondering if you had to have conversations with the state of Illinois about any achieved savings in those first couple of years, how that would impact or not impact your overall payment arrangement under the Medicaid program, your PPS, and if there was an impact and whether or not there was a conversation that had to be had.
We were working with the state on a regular basis during the setup of the ACO. But they did not tell us that we had to be concerned about our reimbursement rates or how this arrangement would take place. They were more concerned with negotiating with the payer, with County Care, over what their rate was going to be. And there's definitely been, I think, some tension around that, and I'm sure that going forward that rate will change based on a variety of factors. And so, of course, this is all a moving target, and we just have to make sure we stay caught up with all of the changes.
Yeah, I think you're absolutely right. It definitely is a moving target, and the reason why I was asking the question is I've chatted with both FQHCs and then various different Medicaid agency, either directors or folks within Medicaid agencies across the country, one of the things that has come up is from the Medicaid perspective, and one Medicaid agency jumps to mind where the Medicaid director mentioned to me and said, hey, that shared savings comes in because essentially FQHCs are supposed to be cost-based reimbursed. This is extra monies that are coming in, and it's through the Medicaid program. We should be able to take that back. And so I know what we did here in Minnesota is very much and very early on into the negotiations with our state Medicaid agency, we actually ensured that there was a carve-out and recognition that the monies achieved by the Medicaid ACO would be separate and distinct from our Medicaid PPS, and our state agreed to that. But I think it's as we're all contemplating moving forward with this, those are one of the things. And Rich, given the uniqueness of what you've got done in Hawaii, I'm assuming, but I don't mean to, well, I do mean to, but perhaps I'm wrong, that was a non-issue for you guys, given the construct.
No, actually, before we embarked on this, we wanted to make sure that we had, that this was all resolved in terms of the PPS rules and what we could receive without it being an offset to PPS. And the fundamental thing here is, what is an aligned incentive for health centers to address preventable costs and improve quality and access? So from a systems perspective, how does that incentive work? So what we did is, and it's been several years now, we went to the state legislature. We put a bill through that defined how the PPS would work in Hawaii. And in that law, it said that any payment for continuous quality improvement, investment in infrastructure, or gain share would not be offset against PPS. And that was approved by the legislature, put into a state plan, a Medicaid plan amendment, and then approved by CMS. So before we did any of this, we got this into state law, and we got CMS to approve the model.
Well, that's tremendous, Rich, and thanks so much for going ahead and taking care of that precedent for us, right? So I'm not seeing, Mac, do you have any other questions from SNAC directly? I'm not seeing any other questions coming through at this time. So anything from your perspective?
No, nothing else on our end. Don, I would be interested in your reactions too. I know you've been involved with a lot of this, and you have some great resources through your perch at NAC. Any thoughts or reactions in our last couple minutes here?
No, I mean, just thank you so much to both Dan and Rich and Jason for their really insightful information and sharing their experiences with us. I mean, there's amazing stuff going on across the country right now. It's kind of a little daunting, but also very exciting. And we are here to support the primary care associations and the health centers as they kind of engage in this effort. And again, we have resources on the website, but are always, happy to hear from folks as well from the field.
Wonderful. Well, thank you very much, everyone. Thank you, Rich, Dan, Jason, and Don. This was a great session, and thank you to everyone for attending. We're glad you're able to join. Please do check out the resources available through NAC and at SNAC. We'd be happy to connect with you and learn more about what you're doing, and wish you nothing but the best on your payment reform journey. So with that, thank you very much, and we look forward to next time.